Hello and welcome to the Answers for Cancers podcast. I am your host, Anne-Marie Fay.
And I'm Michelle Matthews.
Together with some of Ireland's leading experts, we want to unravel what it truly means to have cancer.
From consultant diagnosis to treatment plans, from managing your symptoms to supports available, we have it covered. So whether you're a nurse working in oncology or have been personally affected by cancer, this podcast is for you. The Answers for Cancers podcast is sponsored by Care Plus Pharmacy. Care Plus Pharmacy is Ireland's leading community pharmacy brand, offering expert advice and services for a healthier and happier you. Find your nearest Care Plus on www.careplus.ie or follow them on social media for health and wellness inspiration and tips. Today on the podcast, we are joined by a very special guest who is Professor Desmond Carney, who's going to cover breast cancer with us. I suppose before I begin, I don't think any introduction that I do is going to amount to the amount of work that this man has done over the years for medical oncology, and we just feel extremely grateful to have worked with him. He retired earlier this year, but he has left behind him an absolute legacy. When myself and Anne-Marie decided to start this podcast last year, Professor Carney was the first consultant that we spoke to, and despite the fact that he had no idea what a podcast was, he still agreed to jump in head first and be the first consultant that we recorded with. And he gave us the confidence to go on and pursue it, and reassured us regularly that we were doing a good thing, because it was very, very nerve-wracking starting this up. Not only that, when we recorded it, because it was the early days, myself and Anne-Marie recorded it completely wrong and the sound was awful. So he then agreed to come back on the podcast and re-record it again with us, just to ensure that we were getting the best quality of education out there for our patients. So we just feel extremely grateful to him, not only for the time that he's given us for the podcast, but in general, all the education that he's given us over the years that we've worked with him. It's been an absolute pleasure. Like I said, he did retire this year, but I don't think I'm going to be able to say enough about him, but just a couple of things. If you do ever go to get your chemotherapy in the Mater Hospital, you'll actually be getting it in the Carney Oncology Haematology Day Unit, which was named after Professor Carney, and there's a painting of him on the wall as you walk into the unit. Not only that, he was also instrumental in establishing the ARC Cancer Support Service, which you may have heard before a few episodes ago, how important that is for our patients and how much benefit patients and their families get from this support. So again, we're just extremely grateful to Professor Carney for giving us the time to speak to us on the podcast today about breast cancer, and also all the time that he's given us over the years that we've worked with him.
So good morning, Professor Carney. Welcome to the podcast. We're delighted to have you here today to talk about breast cancer. So we'll start with the basics, and if you could just explain what breast cancer is and how common it is in Ireland.
Breast cancer is a malignant transformation of the cells within the breast. Obviously predominantly affects women, although a small proportion of males will get breast cancer. Throughout their lifetime, there's about 1 in 9 females will get breast cancer, and it affects all age groups, and all different races can get it. What causes breast cancer? For the majority of people, they've no family history. Some people have a strong family history, and we'll talk about that a little bit later. Prolonged use of hormone replacement therapy may increase the risk, but only by a small amount. Breast cancer is usually diagnosed by the woman themselves, and a lot of people, by feeling a lump. Mobile, doesn't go away, not necessarily related to their menstrual cycle. Screening programs also pick up a lot of women with breast cancer, and the whole idea of screening mammography is that you can detect breast cancer early. By detecting it early means less aggressive surgery, less aggressive treatment, and a much better outcome. Breast cancer is diagnosed in many different ways. Patient tends to be referred to a surgeon for triple assessment. That means a physical examination, a mammogram, plus or minus an ultrasound, and then a biopsy. Occasionally, for younger women particularly, an MRI of both breasts may be carried out. It's also important that if a mammogram is done, it's done on both sides, even though that you may feel the lump on one side or the other. A biopsy is usually done at the first sitting, and that's known as a core biopsy. And from that you get an idea of what the type of breast cancer it is, if it is indeed breast cancer, and how to deal with it. If you feel anything in the lymph nodes, there's often a core biopsy of the lymph nodes done, and I'll come back to that a little bit later. Once the biopsy is taken, the pathology is really important. That gives you an idea if you're dealing with ductal carcinoma in situ, which is like not truly pre-malignant, but it's DCIS, which doesn't spread in the same way like the cancer does. Then you've got ductal carcinoma, lobular carcinoma, or a mixture. The key studies to be done are the grade, meaning how aggressive is the tumour. Is it estrogen positive, progesterone positive, or HER2 positive? And those three biological markers dictate how the person may be treated once the final diagnosis is made. So they are critical assessments that are done early on in the stage of the evaluation of a lady with breast cancer. If the histology is that of DCIS, the management is totally different than an invasive carcinoma. So the key thing to separate out at the beginning is ductal carcinoma in situ, i.e. DCIS, or invasive carcinoma. If the person has DCIS and you've detected it on a screening mammogram and an MRI, and if it's amenable to wide local excision, the treatment is surgical removal alone, followed by local field radiotherapy. If it's multifocal, meaning throughout the whole of the breast, then that person may need to undergo a mastectomy. All of those options have to be discussed with the patient. Some people may decide, I want a mastectomy because I don't really want to go through 4 to 6 weeks of radiation, or I have a family at home and I need to be at home for them. So all of these treatment decisions, surgery particularly, has to be discussed in detail with the patient. So DCIS, confirm the diagnosis, do your mammogram, your MRI, and do your surgery. If it's a wide local excision, which is a lumpectomy, that then is followed by radiation. And radiation is roughly 4 to 6 weeks of radiotherapy on a daily basis, Monday to Friday. The other type of breast cancer is invasive ductal carcinoma, invasive lobular carcinoma. That's truly cancer. It's invasive. And if it's not managed properly, has a risk of spreading to the other organs, the local organs first, and distal metastasis. So if you do your biopsy and it's an invasive breast cancer, and generally you also try and look at the axilla as well to see if there's any lymph node involvement. And if on the ultrasound or indeed the mammogram you see lymph node involvement, prior to doing your surgery they will often do a fine needle aspirate or a core biopsy of the lymph node, because that may dictate the type of surgery the person needs. You've done your physical examination, you know it's an invasive cancer. The treatment is now surgery, followed by either radiotherapy, hormonal therapy, chemotherapy, or a combination of all of the above. Are you with me so far?
Yeah.
Yep.
The planning of the surgery is the same as that for DCIS. How big is the tumour? Is it amenable to a wide local excision? What is the patient's option? What do they want? In general, for small lesions, the surgeon does a wide local excision and what is known as the sentinel lymph node biopsy. The sentinel lymph node is detected by a dye test at the time of surgery, and the dye goes to the first lymph node that you might assume cancer cells would go to. And that lymph node is removed at the time of the wide local excision for the primary tumour. So the initial assessment of a patient for a small lesion is a wide local excision and a sentinel lymph node biopsy. You wait for the full pathology results to come back. How big is the tumour? Are the margins clear? What's the grade? Is the lymphovascular space invasion? And as before, the estrogen receptor, progesterone, and HER2 status. If the sentinel lymph node is negative, no further surgery is really considered. If the sentinel lymph node is positive, there will be a discussion whether you need to go back and remove all the glands in the axilla, which is a lymph node dissection, or at least some of the glands, because that will dictate further treatment as we move forward. If the lesion is very large, say more than 4 or 5 centimeters, and it's not clear that they can get full surgical removal, sometimes a mastectomy is the best treatment option for that patient, with the sentinel node or lymph node biopsies at that time. We'll come back to it later, but for some people with a large tumour, you may consider preoperative chemotherapy. That's only in the minority. So we've done our surgery, we've done a wide local excision, we've done a sentinel node biopsy. Now the treatment is, what further treatment does that lady need? Well, if she's had a wide local excision, she definitely needs radiation to her breast area. Otherwise the risk of coming back in that breast, in the ipsilateral breast, is too high. So that post-operatively, the patient will be considered for radiotherapy. The systemic treatment, meaning to try and prevent the cancer coming back, can be hormonal therapy if it's estrogen receptor positive, or if there's a lot of lymph nodes involved, chemotherapy. And for a small proportion of people who are positive for the HER2 receptor, they get an anti-HER2 agent such as Herceptin. Once the surgery is complete and we've got the full results from the pathology department regarding the primary tumour, the grade, its size, estrogen status, HER2 status, the nodal status, we will then make a decision about whether that person needs any further systemic treatment.
And by systemic treatment, you mean chemotherapy?
Chemotherapy or hormones or anti-HER2 treatment. Radiation therapy has different set of criteria than the role for systemic treatment. They're separate.
Okay.
Some people will consider that all patients who have a diagnosis of invasive breast cancer should undergo staging procedures post-operatively before systemic treatment takes place. You could say an early stage disease doesn't need it, but perhaps it might be useful for everybody that they have a CT scan and a bone scan to make sure it hasn't spread.
Mm-hmm.
If breast cancer spreads, the most likely places it will go to will be bone, and then to the visceral organs such as lung and liver, or to the draining lymph nodes, which would be the axilla, the neck, and the mediastinum. So your scanning is really looking to see if the cancer has already spread at the time of diagnosis. For any of our patients that we're considering for systemic treatment like chemotherapy, we would always do the scans before we start.
And if you weren't considering chemotherapy, you wouldn't scan?
I still might.
You might. Because I suppose the biopsy is only as accurate as to where the needle goes, isn't it?
No, the biopsy, the first biopsy you do is to confirm the diagnosis.
Mm-hmm.
DCIS versus invasive cancer.
Mm-hmm.
Then you plan your surgery, and you've done your lumpectomy plus the sentinel node and axillary dissection. Now you've got an invasive cancer with lymph node involvement. They need systemic treatment. By and large, most of those patients would be scanned.
Okay.
Don't let me forget oncotype testing.
Yep.
Yeah, no, definitely.
So I think we've talked about the surgery, which is a wide local excision versus a mastectomy.
Mm-hmm.
In general, it's followed by radiotherapy for most patients. There's a sentinel node biopsy done at the time of surgery. If that's positive, more auxiliary surgery may be required.
Yep.
We've now done our surgery. We have the results. We're now having to decide what type of treatment the patient needs further. We did say they needed radiotherapy if they had a wide local excision.
Yep.
Or indeed some people have had a mastectomy for a large tumour. Positive margins will also need post-operative radiotherapy. And patients with significant lymph node involvement will also need post-operative radiotherapy. And that radiotherapy is 4 to 6 weeks, Monday to Friday. Two main side effects: radiation burn in the chest wall. Rarely do people get a burn, they get a bit of redness, but they get quite fatigued as they get towards the end of the radiotherapy. The timing of the radiotherapy is done in conjunction whether there's a plan for that patient to get further systemic treatment, plus certainly chemotherapy. In general, if they're just getting hormonal therapy, the radiotherapy is done about 6 weeks after the surgery when the wound is fully healed.
Mm-hmm.
If they're getting chemotherapy, unless there's a crisis, the radiotherapy is done at the end of the chemotherapy.
Mm-hmm.
So that's the timing.
And what's the break usually after chemo?
2 to 4 weeks.
2 to 4 weeks.
Once they've got over the neutropenic phase.
Perfect. And for patients who are getting radiotherapy and hormone treatment, would you advise them to start the hormone treatment at the same time as the
Pretty much
radiation?
straight away, yeah. You know, I mean, the side effects of hormones are totally different, but
Yeah.
sometimes it's easier to do one thing at a time.
Yeah.
Can I just ask you to just, you mentioned how the surgical margins determine some of the treatment post-operatively. Do you mind just explaining what the actual surgical margins are?
When the lump is removed from the breast, the pathologist who's going to report it wants to let you know that the edges of the tumour are completely clear.
Mm-hmm.
And that's what we mean by the surgical margins.
Perfect.
If they're not completely clear, either you go back and do more surgery, but you would certainly take that into consideration in planning a radiotherapy.
Mm-hmm.
The ideal is to remove the lump with clear margins,
Yep.
meaning there is nothing left behind.
Yep.
For some people, it's worth considering and discussing with them prior to surgery, particularly if they have to undergo a mastectomy. They might want to consider immediate reconstruction,
Yeah.
and they need to discuss that with the surgeon who's involved and maybe the plastic specialists. Our lady with invasive carcinoma has had her surgery. The margins are clear, the nodes are clear. Does she need any further systemic treatment once she's had her radiation done? So if it's estrogen positive, HER2 negative, consideration will be for hormonal therapy.
Yep.
And hormonal therapy would be drugs that interfere with the production or the activity of estrogen within the lady's body. And they're drugs such as tamoxifen or the aromatase inhibitors such as letrozole.
Mm.
It used to be that if you were node negative, meaning no metastatic involvement of lymph nodes, you would say hormonal therapy will do fine.
Mm-hmm.
But that's a little bit of guesswork, because some people would have an aggressive tumor.
Mm-hmm.
So for all the people who are node negative, estrogen positive, and HER2 negative, or maybe 1 to 3 lymph nodes involved, we do the Oncotype test.
Mm-hmm.
The Oncotype test is a genomic test, a measurement of numerous genes within the breast cancer tumors, and it predicts the likelihood of a recurrence with hormonal therapy alone and the benefit of added chemotherapy. So you might get a recurrence score of 10, which means the likelihood of recurrence over the next 9 years is 10%, and it indicates no benefit from added chemotherapy. You might get a recurrence score of 31, which means the hormonal therapy is not going to be very effective, and that group will need chemotherapy.
Okay.
Even for the person who's an estrogen positive, node negative HER2 tumor, we now do Oncotype tests on them all.
Okay. Mm-hmm.
It takes the guesswork out of what's the right treatment.
So essentially nearly everybody gets it now.
They should all get it.
Okay.
And am I right in thinking it's kind of been transformative in saving kind of over-treating patients who don't need...
It does two things. It gives you reassurance that hormone therapy is the right therapy for this lady. It also selects out those patients with an early breast cancer who actually might need or benefit from chemotherapy.
Yeah.
So it does both.
Yeah.
And that result takes a couple of weeks.
Mm-hmm.
And in general, we would show the patient the results when they come back.
Mm-hmm. Okay.
And it's on a graphic form. It's very easy to read.
Mm-hmm.
And you can do that for perhaps up to 3 lymph nodes as well.
Okay. And can I ask, at what % would be the cutoff that you would decide to
I think it's about 21 or
Is
22.
it? Yeah.
It's up to 26, but it varies on the age of the patient as well.
Okay.
Okay.
And there's a graph, and you can show that to the patient. And the higher the score, the greater the benefits from chemo. So it's giving you an idea how effective hormonal therapy is going to be for that lady. But it also says, some people, believe it or not, will say, should I have chemo as well?
Yeah.
And you're going to say, well, there's no benefit. You don't need it.
Mm-hmm.
Like you say, it takes the guesswork, so that kind
Takes the guesswork out of it.
Yeah.
It's really made a big difference.
Yeah.
So for the person with a small tumor, small number of lymph nodes involved, that's HER2 negative, estrogen positive, progesterone positive, we nearly do an Oncotype on all of them, unless for some reason it's contraindicated. Like if you've got an elderly lady with cardiac disease, you're not going to ever give chemotherapy to, you probably wouldn't do it.
Yeah.
That's just all what I mean.
Yeah.
And can I just ask, how long does it normally take for the Oncotype test to come back?
2 to 3 weeks.
Okay.
It's not long.
Mm-hmm.
You know, the pathology report is usually back within a week, and person is generally seen by medical oncology within a few weeks when the wound is healing. And usually by then, the surgeon would have sent off the Oncotype test.
Perfect.
Okay.
You know, but it's definitely worth waiting for.
Yeah.
Mm-hmm.
So we've talked about HER2. HER2 is a receptor on the small proportion of breast cancer tumors that really predicts quite an aggressive tumor, because the HER2 drives the growth of the tumor cell. And it used to be a negative prognostic marker. Nowadays we have agents that specifically target the HER2 receptor. And the most commonly used one is Herceptin, but there's other ones like pertuzumab, and even down the line a little bit TDM1. Anybody who's got a HER2 positive tumor should be considered for combination chemo with the target agent Herceptin. That will give that person the absolute best outcome. In my opinion, the targeted agent has transformed the outcome of people who are HER2 positive tumors at diagnosis. And we do it all the time. The disadvantage perhaps of Herceptin or the anti-HER2 agents, in a small proportion of people, it can affect the cardiac muscle, the pumping of the heart, and lead to cardiac failure. So all patients being considered for anti-HER2 therapy have to have cardiac assessments done beforehand and be monitored frequently while they're on the HER2 treatment. And in the adjuvant setting, meaning the post-operative setting, the anti-HER2 treatment with Herceptin goes on for a calendar year. So it's almost 12 months of treatment.
Yeah.
Usually the first 6 months of that treatment, it's combined with chemotherapy. Then the Herceptin is used on its own for the second 6 months. That's approximate figures. And the radiation can come in as soon as the chemotherapy is finished. You don't have to wait for the radiation to be done at the end of the HER2.
Yeah.
But they have to be monitored going forward for their cardiac status.
Yeah.
And if I was a patient who got diagnosed with HER2, how do you explain how HER2 acts on the breast?
So what I explain to do it is that, this is really stupid. I explain to the patient, the light switch on the wall is driving the power into the lights. The HER2 is the trigger that drives the cancer cell. We're going to switch it off like we switch off the light. So just to try and make it understanding for any of us.
Yeah.
It's a compound within the cell that's driving the cell, making it behave more aggressive. Herceptin blocks that. So it's turning off the switch. And that's what it does.
That's a good way of prescribing.
That's the way I point to the light switch when I'm trying to explain it to them and say that's what it does. It's turning that driving off.
It's the easiest way to absorb it, just a simple analogy like that.
It's a simple.
So,
And in many ways that's what it does in a more technical way.
Yeah. I don't want to see the pictures I've drawn for people trying to explain it. So
no, but just think of the light switch.
That's a good way. Yeah.
You turn the light on, it's driving the power.
Yeah.
You turn it off, it turns it off. That's what Herceptin does. So we've talked about the radiation therapy. We've talked about the systemic treatment. So I'm just going to very briefly mention, we've talked about hormonal therapy, such as tamoxifen, or for more older women, aromatase inhibitors such as letrozole or Arimidex.
So tamoxifen is premenopausal?
In general.
Yeah.
But if you've got a lady with hypercholesterolemia, bad arthritis, an aromatase inhibitor will not suit her, and I will use tamoxifen in that situation.
Yeah.
So if they've got a cardiac disease, osteoarthritis, hypercholesterolemia, I'm going to use tamoxifen instead of aromatase inhibitor.
Yeah.
There's a marginal benefit of the aromatase inhibitor in the postmenopausal ladies.
Yeah. And again, these are for the ER positive.
ER positive.
Yeah.
ER positive patients.
Yeah.
In general, hormonal therapy is for a minimum of 5 years.
Yep.
In general. For people at high risk, so you've got a young lady, you've done her surgery, she's got 10 lymph nodes involved, you know her risk of recurrence is higher, you may continue on the hormonal therapy for 10 years.
Okay.
Now you have to balance everything up. One of the advantages of tamoxifen, it doesn't cause osteoporosis. The aromatase inhibitors will cause osteoporosis. So you take all those into consideration when you're planning which hormone to give them.
Yeah.
And
there's no question about it. The tamoxifen, for sure in younger women, will cause menopausal symptoms. A little bit of nausea, vaginal dryness, night sweats. In general, they settle into it. And the first month or two, there's also a lot of background nausea with the hormone therapy. Sometimes I tell patients taking it at night. I think it's a bit easier, but I don't know if that's really scientifically proven or not.
Okay.
And would a patient need to be monitored on tamoxifen if they're on, like in a hospital, would they need to have their bloods done regularly?
No.
No.
So generally, for patients who are on hormonal therapy alone, either they're seen by the medical oncologist or the surgeon and can be just followed. So once they've settled into it, in general, I wouldn't do any more than 6 monthly visits.
Okay.
Knowing that they can contact the team at any time in between if there's any issues. And they must have a screening mammogram done annually going forward, almost forever.
Okay.
For the people with a low risk estrogen positive tumour, perhaps hormonal therapy for 5 years is sufficient. For a high risk, meaning they node positive disease or acquired chemo, you'd keep the hormones going for 10 years if they can manage it.
Yeah.
And in the premenopausal women on tamoxifen, you can't conceive when you're on that. Am I right? Okay.
So you need to use, and it's not necessarily contraceptive. The one thing about tamoxifen that's always worth remembering, lots of people travel and fly and have surgery. They need to be aware that there's a risk of a clot with tamoxifen.
Okay.
So if they're having surgery, they should stop it beforehand, or at least talk to their surgeon. Or if they're going to Australia, probably should stop it before they fly.
Okay.
And wear the stockings and flex, all those things that we do to prevent clots anyway. In general, tamoxifen is really well tolerated. But you have to be aware of the side effects, particularly for younger women.
Okay.
When is chemotherapy indicated? So we're talking about the lady who's post-operative. Chemotherapy should be generally considered for people, younger women with significant lymph node involvement, or people with a high oncotype score, or people who are HER2 positive.
Yeah.
There's a number of different chemotherapeutic regimens available, and the choice of what to use will depend on particularly the performance status of the patient, the cardiac status, their fitness level, have they a neuropathy, are they on drugs for arthritis, what other medications are they on. And I don't think there's a lot to be gained by going through the different regimens.
Okay.
In general, for people who are fit enough who need chemotherapy, we use a regimen called dose-dense AC Taxol, but there's other regimens for the elderly person that you might consider.
Yeah. Yeah.
If they're HER2 positive, Herceptin is added to the chemo in the adjuvant setting.
Yeah.
So the classic example again is AC Taxol. We would use AC Taxol plus Herceptin. And as we mentioned earlier on, the Herceptin goes on for 12 months, provided their cardiac status remains stable throughout.
Yeah.
And is that why they give the Herceptin with the Taxol and not the AC because of cardiac?
They're both cardiac toxic.
Okay.
So once you've done, I know we all do our echocardiograms and ECG at the beginning. Great, it's fine. Got to repeat it again before you start the Herceptin.
Yeah.
In general, are people at high risk of recurrence, and high oncotype score, significant lymph node involvement, or anybody who's HER2 positive.
Yeah.
We'll get back to that conversation in just a minute. I wanted to take a moment to talk to you about our immune systems. While we're all so looking forward to spending more time with friends and family this summer, it's really important to give your immune system a much needed boost in order to protect yourselves and the ones that you love. Strengthen your immunity naturally by visiting your local Care Plus pharmacy for expert advice on a wide range of vitamins and supplements available. Now back to our conversation.
Chemotherapy is given in general in an outpatient department. Because it's given quite frequently, for those ladies who require it frequently, we often consider putting in an interport to allow easy venous access when they come to the day ward. Every patient coming to the day ward has to have their bloods checked, and then they get their chemo, and then they go home. So it's quite intensive for the patient, and if they're particularly getting the chemo every 2 weeks or weekly, it's quite tough on them going forward. The chemotherapy is generally lasts 4 to 6 months. If they need Herceptin, that's added to the chemo. For example, the regimen AC Taxol that we use for a lot of ladies getting chemo, we would add the Herceptin to the Taxol component of the arm.
And the biggest side effect with the Taxol is kind of the peripheral neuropathy.
Peripheral neuropathy.
Yeah.
Not so much, hair loss, don't forget.
Yeah.
Universal hair loss. Almost everybody getting chemotherapy, almost everybody, unless they're elderly getting different regimens, will have hair loss. We're much better at managing the immediate side effects such as nausea and vomiting. Peripheral neuropathy is a side effect of the Taxol. Cardiomyopathy, damage to the heart, is a side effect of Herceptin and adriamycin. And most patients on chemotherapy get lowering of their white cells, platelets, or red blood cells, which makes them more predisposed to infection. Patients have to be informed of the risk of infection with a low white count, so they have to contact the unit immediately if they get a temperature between the courses of chemotherapy.
Yeah. And we can give Neulasta for that, don't we, with the AC?
So if there's a big risk of the patient getting lowering of the white cell count, which is called neutropenia, there's a drug that we often use called Neulasta, which helps to maintain or speed up the recovery of the white cells. So even though the white cells might go low, the risk of them getting an infection is much less. And if you cut down the risk of infection, you keep things going on schedule, which is important.
Yeah.
We have discussed today the patient who comes in with a surgical removal breast lump.
Yeah.
Some people present extremely late with a very large tumour that would make surgery difficult, or what is known also as an inflammatory breast cancer, where the whole skin in the area of the breast is red and inflamed. Those people have a core biopsy to confirm the diagnosis. They have staging scans done, such as a CAT scan and a bone scan, to make sure they don't have metastatic disease, or whether they do. And those patients are now considered for neoadjuvant or pre-operative chemotherapy. That's where we give the chemotherapy first, in the hope that we can shrink the tumour down and then consider them for surgical resection. So that we go through the same process. The biopsy is done. Is it estrogen positive, progesterone positive, and particularly if it's HER2 positive. If it's HER2 negative, they tend to get treated with the same chemo that we've generally used, such as AC Taxol. Being monitored closely, hope you can shrink it down and make it amenable to surgery. All of these people will have a mammogram and many will have an MRI before you start your treatment. If they're HER2 positive, then they get chemo plus anti-HER2 agents, and they usually get chemo plus Herceptin plus pertuzumab. Those two agents together with the chemo increase the pathological response rate, making it more amenable to surgery. Mm-hmm. These people are evaluated closely as you're going through the chemo, because not everybody will respond. Mm-hmm. In some people the tumour will grow and get worse. But they usually a very aggressive tumour, they presented late, it's inflammatory. The most people that will shrink it down to make it amenable to surgery. And again, when you've completed your chemo plus your anti-HER2 agents, you repeat your mammogram, you repeat your MRI, the same surgeon is involved, and hopefully will do the surgery, which for most people will be a mastectomy. Mm-hmm. And then you'll evaluate the pathology response. Some people have no tumour left. Some people will have a mixture, like 50-50. Some people have had no response. Mm-hmm. But all of them will require post-operative radiotherapy. Mm-hmm. Okay. And then if they're estrogen positive, they go on hormones as well. So the management of in the neoadjuvant setting, it's very key to know the pathology and the HER2 status. Mm-hmm. Does that cover that?
Yeah, yeah. Can I ask, if somebody is metastatic on diagnosis, are they treated as aggressively, ACT and that, or does it slightly change?
So about 10% of women have metastatic disease at diagnosis. That means it is spread beyond the confines of the breast and the draining lymph nodes. Mm. And frequently you'll find that it's in the liver or the lung or in bones. Your management is very much dictated by how bad the metastatic disease is. If you've bone-only metastasis, you may live for many years. So your approach to treating the primary breast tumour may be the same as if they didn't have metastatic disease. Maybe. Also depends on what the patient wants. Mm-hmm. Because when you've metastatic disease, with the current treatment we have, we're not going to cure it, but we can control it for many, many years. So that discussion needs to be had with the patient. Mm. If they have significant metastatic disease involving their lung or their liver, and in rare cases their brains, managing that is the priority over managing the primary tumour in their breast. So the treatment of the person with metastatic disease is treating somebody with metastatic breast cancer. So you're going to use the same drugs. Mm-hmm. And it really depends upon, is this person going to get into a crisis quickly from their metastatic disease? Okay. So you've come, for example, somebody comes in and they're short of breath from their metastatic disease in their lung. Mm. You don't have a lot of time to get a response. So those patients will generally be considered for chemotherapy if they're fit enough. Yeah. If someone comes in and they have a few lesions in their bones, but their liver, brain and lung are clear, you might just put them on systemic treatment with hormonal therapy. Yeah. So a lot depends upon the fitness, the performance status, and the extent of the metastatic disease.
Yeah. You know, in your experience, that 10% of women that present metastatic at diagnosis, like, are they generally symptomatic, or like how, when it's got to that stage?
They usually are symptomatic. Mm. One of the key things, I would say the most obvious thing, is to examine the patient.
Yeah.
Mm. You know, you find a knoll in the neck, they're not going to know about it. Mm. You feel maybe. The other key thing is also check the other breast.
Yeah.
The lady comes in and says, I have a lump on my left side. Mm. You better check the other side, because they might have checked it themselves. Very few people, they find the lump themselves because they're stretching in the shower and they see a dimple or something along those lines.
Mm. Yeah.
But a lot of people are symptomatic when they come in.
They are, yeah.
And, you know, and when you're following up people in your clinic who've had it early stage breast cancer, maybe got chemo and hormones, and now coming back for regular review, listen to them.
Yeah.
But there's no evidence that doing scans every 6 to 12 months has any impact upon their outcome.
Okay. That's good to know.
Because
patients are very focused on scans.
We'd have
stuff,
hundreds of patients coming back who've never recurred.
Yeah.
And they're 15 years later. if we kept doing scans on them, they'd have no quality of life.
Yeah.
But every time they have a scan, they're worried about what is he going to find in the scan.
Yeah.
So I would only do scans on patients who develop new symptoms. You know, if the lesion has metastatic disease at diagnosis, then you're going to do scans every 3 to 6 months to see if they're responding to your treatment.
Yeah.
You know,
Yeah.
a small proportion of women, like probably less than 10%, more likely 5%, will have a hereditary cancer gene called BRCA1 or BRCA2. In general, they're younger, and they give a strong family history of breast cancer, ovarian cancer, or both, or indeed male breast cancer in their family. In general, people who have these hereditary cancer BRCA genes, breast cancer associated genes, are younger when they get their breast cancer and have a certain subtype of breast cancer which we call triple negative, meaning their tumours do not express any of the markers that we normally look for: estrogen, progesterone, or Herceptin. They tend to be a more aggressive type of breast cancer. So generally anybody with a triple negative breast cancer will undergo surgery, post-operative radiotherapy if required, and systemic chemotherapy. And then they get followed up closely on an outpatient basis.
Okay.
We talked about the role of immunotherapy in breast cancer. It's beginning to have a role, particularly in the triple negative breast cancers. So if a lady with triple negative breast cancer who's got her treatment and then 2, 3, 4 years later recurs, and you put her back in chemotherapy, then immunotherapy has been shown in that particular situation to prolong the response rate.
So if somebody presents as triple negative breast cancer, should they be tested for BRCA?
Yes, they should be. Or if they have a strong family history.
So you need to present with triple negative or have a family history.
If you have a strong family history and or triple negative breast cancer in the young age group, you should do genetic testing. For the patient themselves, if they're BRCA positive and you've dealt with their breast cancer and everything is perfect, then you would consider removal of their ovaries to cut down their risk of getting ovarian cancer.
Yeah.
So the BRCA genes increases your risk of getting breast cancer, ovarian cancer, or both.
And if you are BRCA positive, what's your say if my mum was BRCA positive, what's the percentage of me getting it, do you know?
It's quite high.
Is it? Yeah. And if you carry the BRCA gene, it's a really high percentage of getting breast cancer, isn't it? Or
it is very high. So so in general, if one's mother is carrying the genes, you could say you have a 50-50 chance of getting one of those genes. But it doesn't quite work out like that. It could be less or more. It could be 100% or 50 or 0%, because you have a good gene and a bad gene. If you get the bad gene with your father's gene, you're a BRCA carrier. But you could get the good gene from your mother as well as from your dad and not be a BRCA carrier.
So if that happens regularly enough, do you think that if you find out you have the gene, you can...
The number of people with the gene is quite low. But I mean, in general, we would discuss oophorectomies with them. Because, and whether they want the surgery on the other side or not is very much their decision. I've had some young people who just bilateral mastectomies. Others who don't want to know about it. But at least you're going to be monitoring the person from their breast. Very hard to monitor the ovaries. There's one other small area where one needs to be very careful in monitoring people for the risk of breast cancer. Young women get Hodgkin's lymphomas, like young men. And part of their treatment frequently involves mediastinal radiotherapy. That will increase your risk of getting breast cancer. So they have to be monitored a little closer with frequent mammograms at a younger age. It's a very small proportion, but we have all got a small number of these patients.
Okay, it's good to know. I never knew that. Yeah.
No, it's pretty. It just struck me there. I was just thinking about
that's really good to know.
I was thinking of somebody I'd sent out to, I think Janice Olsen, Vincent's recently, who got radiation-induced breast cancer.
Okay.
So, bone-modifying drugs and breast cancer. So patients who get metastatic breast cancer that involve their bones, one of the fears used to be that these people would get fractures in the bones that were involved, which could be very difficult to heal, impact upon their quality of life and their mobility. So we're very much aware that when we find somebody with bone secondaries, that we scan their bones to make sure they're not at high risk of a fracture, because if they are, we'll do preventative orthopedic surgery. Or sometimes you'll use radiation for those bones. But we use a class of drugs called the bisphosphonates, and one of them is known as Zometa. And I often call it the bone hardening drug.
And earlier on when you were talking about the aromatase inhibitors and saying that can sometimes predispose you to osteoporosis, do you use the bone strengthener in that instance?
No, I tend to just put them calcitude D3 with it.
Great.
Okay.
Some people would give a bone strengthening drug like Zometa.
Mm-hmm.
In the adjuvant setting, it seems to have some small benefit, but I'm not sure if that's universally accepted.
Yeah. Okay. Perfect. And I think, you just mentioned there pregnancy and cancer.
Pregnancy and breast cancer.
Mm-hmm.
So women get breast cancer, women become pregnant.
Yeah.
And you'll often find somebody coming in for their first checkup, maybe at 12, 14 weeks pregnant. And bingo, they have a lesion in their breast.
Yeah.
What do? You can do the exact same surgical approach as you would if they were not pregnant. So that person, you do your core biopsy, and if it's malignant, you can go ahead and do your wide local excision and your sentinel node biopsy or auxiliary biopsies. We don't do CT scanning. You don't like doing a lot of radiology in people who are pregnant, but if you have to, you do it, particularly if they're symptomatic. In general, if it's a very early stage, you can hold off your radiation and your systemic treatment. But if you've got a lady who's now at 20 weeks and has got a large tumour and lymph node involvement, what are you going to do? You can actually give chemo from 24 weeks onwards.
Wow.
Yeah. Can you give AC?
Yeah, from 24 weeks onwards.
Okay.
You have to monitor them, and you do it very closely involved with your obstetricians. So what you might consider, and I'm not the obstetrician, that if the baby is developed normally and a good weight and height, you might do an early delivery to cut down the exposure of that fetus to chemotherapy.
Okay. Just while we're on the topic of pregnancy, actually, and breast cancer, Zoladex. When would you give Zoladex?
In general, Zoladex is given to the premenopausal woman
to
cut down their menstrual cycle. It also, if you like, eliminates the risk of them becoming pregnant. But in general, you use it in the premenopausal women to cut down hormone production.
So if you're ERP or positive?
HER2 negative.
HER2 negative.
With tamoxifen. And the other question is, and I should have looked it up, what happens if you've got a young lady, she's 24, 26, she gets her chemotherapy, and now she wants to become pregnant? I think if she's disease-free for 3 to 5 years, it's safe.
Yeah.
There's always a risk of breast cancer coming back.
Yeah.
And one of the big things, I'm not trying to alarm people, even if you're estrogen positive, you can relapse years later. I've a couple of ladies up in the day ward who had their primary breast cancer 19 years ago and now in treatment for contralateral breast cancer. So they've got to be followed forever, and they got to have their mammograms on an annual basis.
One thing actually we didn't mention is males with breast cancer. So I know it's a small proportion, but is it the same treatment?
Same planning and treatment.
Same plan and treatment.
And they tend to be estrogen positive.
Okay.
You know, for every, I think it's about 10 women, you've one male. I have a very small number of male.
Yeah.
And they all, you manage them the same way. You do your surgery, you do your lumpectomy. In general, they get radiotherapy.
Yeah.
Because they don't have a lot of tissue, so the lesion is quite close to the chest wall. And then if they're high risk, they get chemotherapy plus radiation. If they're low risk, they might get hormones alone. And usually the hormone treatment they get is tamoxifen.
Okay. Oh, interesting. Okay.
Perfect. Yeah.
Is there anything you want to add, Prof? Have we missed anything at all?
Development, patterns of spread, genetics, diagnosis, pathology, genomic testing, oncotype, staging, treatment planning, multidisciplinary meeting. Did we say that?
You didn't mention the MDT now.
Once a lady has a diagnosis of breast cancer, all their management is discussed at a multidisciplinary meeting. I feel that's really important because at that meeting you've got the radiologists who've done the mammograms, the MRIs, the surgeon who'll be involved in the surgery, the medical oncologist and the radiotherapist. So a joint decision is often made about the best approach to managing that patient. Should we go down the road of surgery first, followed by systemic treatment, or perhaps is the role first to go chemotherapy for the select group with big tumours and inflammatory? So multidisciplinary meetings and treatment planning is absolutely essential for all newly diagnosed patients with breast cancer. And it happens in all the hospitals. They're managing a large volume of breast cancer patients.
Yeah.
Breast reconstruction can be done either immediately or post-operatively.
Is that a choice?
Well, it depends who's available to do it if it's immediate. Personally, I like to know all about the cancer first.
Okay.
Whereas you do a lumpectomy and immediate reconstruction, you find that the margins are positive.
Yeah.
It makes life a little more difficult.
It's a bit messier, isn't it? Yeah.
And most women nowadays are having lumpectomies. So big reconstruction is rarely done immediately.
Yeah.
Obviously, if you have mastectomy and it's affecting your quality of life, then reconstruction should always be considered.
Yeah.
And it's a lot better nowadays because there's specialists in reconstruction surgery who can do really good jobs. Really good surgery.
Thanks for listening to the Answers for Cancers podcast. Please share this podcast with anybody who you think it might help. Also, if you can like and subscribe, it lets people know we're here. You can alternatively contact us on Instagram at the Answers for Cancers _podcast. And if you've any questions on anything that we discussed today, please email us at the answersforcancerspodcast@gmail.com,